Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington. It's the end of the year, and that means it's time to reflect on the highs and lows. And so here is my top 5 most influential presentations and often publications in the field of thoracic oncology, along with some context for why I think these are justifiably the top 5. The first two I wanted to cover are almost a tie, pretty much a matching set, and that is KEYNOTE-407 that looks at chemo with pembrolizumab in squamous non-small cell, and then KEYNOTE-189, very similar trial in non-squamous non-small cell. But I'm going to talk about KEYNOTE-407 first, give it a slight nod as the most influential, just because before 2018 we didn't already have an approval of a regimen of chemo and pembrolizumab in the first-line setting. And it was also somewhat of a sleeper going into ASCO, and I think has been especially important in that setting. So let's review the study design for KEYNOTE-407. It is a randomized phase 3 trial, first-line setting for squamous non-small cell fit patients. Patients could have any degree of PD-L1 expression from negative to low to high, and they were randomized 1-to-1 to chemotherapy backbone with either pembrolizumab or placebo. And in this squamous trial, the chemotherapy backbone was carboplatin with either standard solvent-based paclitaxel or nab-paclitaxel. And patients who didn't progress after the first 4 cycles, didn't have toxicity issues, went on to maintenance pembrolizumab or placebo. Patients who progressed on the placebo arm could cross over to pembrolizumab. The trial was positive across multiple efficacy endpoints, but most impressive to me at least, and I think to most people, was overall survival at this second interim analysis. You could see that it is really an impressive separation of the curves that is sustained over time, highly statistically significant. And this led to an FDA approval for this regimen in the setting of previously untreated first-line squamous non-small cell. What's particularly impressive as well to me is seeing that the overall survival benefit across the PD-L1 subgroups was every bit as good in the negative and low PD-L1 groups as it was in the highs. As shown in this figure, you can see that the separation is quite striking even in those patients with tumor PD-L1 expression of less than 1% or 0. I would consider that this regimen of carbo with the taxane and pembrolizumab is a clear standard of care for those fit patients with low or negative PD-L1, and it's a strong option as well for those with high PD-L1, though in that setting I would also strongly consider pembrolizumab monotherapy as a well-supported option. Turning to KEYNOTE-189, it's a remarkably similar looking trial. It's a 2-to-1 randomization, first-line non-squamous non-small cell, no EGFR mutation or ALK rearrangement, and patients could have any degree of PD-L1 expression, again, negative, low, or high. Here, chemo backbone with either pembrolizumab or placebo, and the chemo backbone is cisplatin or carboplatin with pemetrexed for this non-squamous population. And again, patients on the placebo arm could go on to cross over and get pembrolizumab upon progression. The trial was highly positive for an overall survival benefit. This was presented and published by Dr. Leena Gandhi in April of 2018, and here you can see just eye-popping differences in the overall survival curves. They are remarkably separated over a long time, and it's impressive also to look at that 1-year overall survival difference of 20%, from 49 up to 69% with the triplet combination. So this also is a clear standard of care, and when we break it down by overall survival by PD-L1 expression, you can see that it's most impressive in the high PD-L1 group, but the curves are clearly separating for the lows and the negative PD-L1 group, all favoring the chemo and pembro combination. The FDA had already approved carbo-pem-pembro based on the much smaller phase 2 KEYNOTE-21G trial, but with this presentation of a much larger phase 3, it really changed the standard of care for me and I think many other people to make this an overwhelmingly compelling option. Again, for the patients with low or negative PD-L1, also a good option for those with high PD-L1, but again, in the high PD-L1 group, pembrolizumab monotherapy also being a strong option to consider. Turning to number 3, at least my number 3, it's Empower-133, and this is in the setting of small cell lung cancer. I think this is going to be a little more controversial. It looked at carbo and etoposide with atezolizumab versus placebo in previously untreated extensive stage small cell. And this trial was presented and published just in the fall of 2018 and shows an overall survival benefit you can see in the curves here. It is statistically significant, I would argue also clinically significant, with a hazard ratio of 0.7 favoring the triplet. Some would be more inclined to minimize the benefit here, the median being just a couple of months with the atezolizumab arm, but I think that underestimates the impact here. You can see from the shape of the curves that the atezolizumab arm is more impressive over a longer time of follow-up. I would also say that in a setting like extensive stage small cell, where improvements have been remarkably hard to come by, seeing something that I think should really move the needle is particularly impressive. Yes, you get bonus points for showing a clinically and statistically significant improvement in the setting of small cell, where we're going decades before finding measurable benefits. And I think this is a real shot across the bow about immunotherapy. It remains to be seen whether this regimen is going to be the regimen of choice for the next 3, 5, or 10 years. But I think it should be our new standard of care moving forward based on these data, and I think it is quite clinically meaningful. The next one I wanted to cover is the Pacific trial. It's been presented in late 2017 and arguably changed the standard of care a year ago, but it was somewhat more questionable at that time. This year, at the World Conference on Lung Cancer in Toronto, Dr. Scott Antonia presented updated results that were accompanied by a concurrent publication in the New England Journal that featured overall survival on this trial. Now, this study looked at the benefit of consolidation Durvalumab immunotherapy given for a year in patients who had received and not progressed after chemo and radiation for unresectable stage 3 non-small cell lung cancer. This was irrespective of PD-L1 expression. Now, in ESMO 2017, we saw a very impressive improvement in progression-free survival, but hadn't yet seen overall survival. And this year, at the World Conference on Lung Cancer and in the New England Journal, we see an overall survival benefit that is also, I would say, impressive enough to, I think, win over people who might have been doubters before this. This is in a curable setting, and we're seeing overall survival differences that are maintained out at least 2 years and counting. It's about a 10%, even slightly higher than 10% improvement in overall survival at 2 years, and we'll need to see whether this is really sustained out over time and represents a true improvement by this proportion or more, maybe even, years out. But it is, I think, enough to have won me over even last year. But if I had any hint of a doubt waiting on overall survival, this really was enough for me. What I think leaves us questioning somewhat is the subset analysis. This is a post hoc analysis, and you could see that the patients with an EGFR mutation don't seem to get a benefit. We've seen in stage 4 patients with an EGFR mutation really don't benefit much, if at all, from at least single agent immunotherapy. And there is a possibility that patients who receive immunotherapy prior to an EGFR TKI can have a higher risk of pneumonitis. So potential harm, unclear benefit. It's really debatable, although the patients who were who had an EGFR mutation and were in the study, the trial was positive, and so I think many of us feel it's at least worth offering and discussing with patients. Also, at the bottom of the forest plot, you can see that the patients with PD-L1 negative disease don't seem to benefit, but this was not part of the study design, and it's not a large subgroup of patients. Some imbalances here, but really another area where I think it's worth a careful discussion with the patient about whether a year of therapy is likely to benefit them, and we certainly will look forward to getting more data on this question over time. The last one that I wanted to cover is the NEJ or Northeast Japan 009 trial. This is in EGFR mutation positive patients, and it doesn't clearly change the standard of care for most of us in North America at least, but I think it's an important and provocative trial. This was a randomized phase 3 study, first-line Gefitinib with or without carboplatin and pemetrexed, and then patients who had progressed on Gefitinib were intended to go on the same chemo regimen upon progression. So kind of a concurrent versus sequential approach, and how much of a benefit is there from hitting the cancer more aggressively up front. There was a very impressive improvement in progression-free survival, and even though Gefitinib is really the weakest sibling in the EGFR TKI family, the chemo plus Gefitinib arm had a median progression-free survival of 21 months or so, which eclipses what we've even seen with osimertinib. It's somewhat of an apples and oranges comparison, but it is impressive to see what this study got in terms of the sustained benefit with chemo and Gefitinib. And what's also quite impressive is that these differences were maintained over time. There was a significant overall survival benefit, even though these patients lived for years and received several other subsequent treatments. In fact, it's not a minimal or barely significant benefit. It's a 14-month difference in overall survival, favoring the patients who started with the more aggressive approach of carbo and pemetrexed along with Gefitinib, and suggesting that there can really be a benefit to hitting the cancer harder up front and changing the trajectory of systemic disease over a prolonged period of time. So I would say that we need to see additional studies that will look at chemo combinations with an agent like osimertinib. I believe there's studies that are being developed for this. But as a general concept, the idea of hitting the cancer harder up front could really have a lot of traction. I'm looking forward to more studies looking at this. So those are my top 5, and I think that it's a somewhat open question. I don't think that everyone's going to feel the same way. I welcome your thoughts, comments, objections, and wish you the best. I hope we have a lot of exciting data to discuss in 2019.